Season 1 of Medsplaining is brought to you by Estee Lauder. With 40 years of night repair expertise and 30 years of collagen research, Estee Lauder are the expert in nighttime skincare. Before we get into today's topic, make sure to subscribe to the Medsplaining podcast on your favorite podcast platform to never miss an episode. Discover the transformative power of Estee Lauder's new Revitalizing Supreme Night Power Bounce Cream. Clinically tested to reduce lines, this moisturizer provides elasticity, bounce, and oil control. Wake up to beautiful, revitalized skin in just one night. When we were just at the very beginning of planning Medsplaining, we scored what I think is one of the best interviewees and experts on women's health in the business. Dr. Jen Gunter, a board-certified OB-GYN, pain medicine specialist, and a New York Times best-selling author whose books about women's healthcare and empowerment are flying off the shelves. We recorded this episode several months ago when Dr. Gunter was in Toronto promoting her latest book, Blood, which is why you'll notice we won't be in our studio. We were actually at the Penguin Random House offices. So if you've ever wanted to see what it's like inside a book publisher, here's your chance. This was a major pinch me moment, an absolutely incredible interview, and it was really fun to be the two Dr. Jens chatting together. So we're going to dive right into that recording. But first, you know what else is a perfect pair? Estee Lauder's Advanced Night Repair Serum and new Overnight Treatment. Boost your nighttime routine with this power pair. It ignites deep nighttime renewal while helping your skin feel recharged and smoother overnight. Together, they deliver dream skin in one sleep. Welcome, Jen. Thank you so much for being here today.
Well, thank you for having me, Jen. We're like the Jens.
I know, we're the Jens. We're the women's healthcare Jens. And your new book is called Blood. It's a bold title. I know you chose it for a reason. So did you want to start by sort of explaining why you named this book Blood?
Yeah, so there is way too much shame about the menstrual cycle. Mm-hmm. You know, the fact that in 2024, people still hide menstrual products on the way to the bathroom. The fact that in some drugstores, you still see menstrual products labeled as feminine hygiene products. The fact that many people don't even know how their cycle works. And that makes them, fall prey to all kinds of disinformation and also bad medical care. And so I feel like part of my role is in, breaking down these patriarchal taboos, saying the word vagina for the Vagina Bible, bringing menopause out to the forefront for Menopause Manifesto. And I just wanted to be like really in your face. This is about blood, baby. And, we're all here because of the menstrual cycle. So we should all be learning about it.
Absolutely. So this book is for anyone who has a uterus, anyone who knows someone with a uterus, anyone who came out of a uterus.
Basically,
yes.
Yeah.
You share a lot of personal stories in here. And I just had this visceral reaction to some of your stories about your early experiences with menstruation. And it made me reflect for the first time in a long time, because I'm now at the other bookend of this, right? On my early experiences and thinking about what did I learn about this in sex ed? And I honestly didn't even get that far because my first memory is that of a really shameful incident where my grade 8 teacher got up and said, she looked around the room, she said, I can probably tell from looking at you which ones of you have had your period yet. And I was very tall, I already had breasts, but I had not had my period yet. And I just remember feeling this intense shame come over me. And then I tuned out everything else she said.
Right.
And so that was my first experience. I asked my daughters, who are teenagers, do you have anything you remember about being taught about your period? And they said, no, nothing.
Yeah, I mean, it's kind of sad that, a generation removed and there really hasn't moved the needle. I mean,
Absolutely.
I think that the average high schooler probably graduates learning more about frog biology than human biology. And I mean, I'll say like no shade to animal physiology. It's an important subject, but schools should also prepare you for life. And so the idea that people are graduating really having very little understanding of their basic biological functions, and then that leads to all kinds of, ramifications and repercussions. So, the whole idea of, sex ed has been really framed as how not to get pregnant, sort of in a way that's very, I would say, like shameful, or puts the onus on, the people who can get pregnant. And it's not any kind of comprehensive discussion. So it wouldn't surprise me that people tune out or remember nothing because, if your only experience is putting a condom on a banana, like that's not really applicable to most people.
Exactly. And you're sitting in this room with often co-ed situation with your teacher, and it's really done in a very awkward way.
Yeah, I mean, your teacher may have no training in how to have this discussion. Your teacher may be passing on myths as well, unless there's somebody who's, really like a certified educator in this area. I mean, just like, if you're a grade 12 math teacher, you probably don't teach grade 12, physics. You probably teach math because that's your area of expertise.
Exactly. And they probably feel just as awkward about it.
Right.
As the kids do. That leads to a situation where you start menstruating. You're already grappling with enough awkwardness as a teenager. And then all you know is your own experience. And so you talk in the book about it's really difficult to know what's normal, what's abnormal. And I think that it would be really important to highlight what would constitute a normal period, a normal menstrual cycle, and then where would some things maybe come up that would prompt a visit to your doctor.
Yeah, so it's really a great point that you brought up that if this is the period you've always had, you don't know if it's normal or abnormal, especially if nobody talks about the mechanics of bleeding. You might know that it's supposed to come about once a month, and maybe it's associated with cramps. And that, that kind of might be what the average person knows. So the menstrual cycle comes anywhere from every 24 to 38 days. So the cycle really can be quite a variation. And it is normal cycle to cycle to have an up to 7-day swing. So you could have a 28-day cycle 1 month and then a 34-day cycle the next cycle. And that wouldn't be abnormal. We consider that normal. If you're skipping periods, that would be abnormal. And if that happens over a couple of cycles, we'd want you to talk to your provider about that. Although understanding in the first couple of years, skipping periods is very common and really not a sign of a problem. Then with the amount of blood, so if you have blood flow that makes you feel like you're gushing, that would be an objective sign of heavy bleeding. If you're bleeding for more than 7 days, if you're bleeding between periods, if you have clots that are bigger than the size of a quarter, or you're needing to change pads and tampons, more than every 1 to 2 hours, or you're leaking onto your clothes.
Okay.
So those would be situations where we would say that's objectively problematic, and we want you to talk to us.
And you talk a lot. You have a whole chapter devoted to painful periods. This is another area where women just accept. We're tough. We're really tough. We will tolerate a lot of discomfort and a lot of pain. Untreated painful periods are costing the economy, $2 billion a year. I'm wondering, is that what led you to specialize in pain medication?
No, I really didn't get into pain medicine specifically because of painful periods. One of my specialties is vulvar and vaginal conditions, and so I'm referred a lot of people with pain with sex. Okay. So that's kind of how I got more interested in it. But obviously, then once you start specializing in pain, then you start to see people with all different other kinds of conditions. And so pain is very undertreated for many people. There are lots of good options for people out there. And a lot of people don't even know, what would be, typical or normal. And I would say, if your pain is interfering with your activities of daily living, or it's not well treated with, with ibuprofen, then that's the time to talk to your healthcare provider. So you've got bad cramps, but you take ibuprofen and you're like, yeah, I feel great when I'm on the ibuprofen, then that's okay. If the ibuprofen stops working, or it doesn't help enough, or, you're really, really incapacitated, then that's the time to discuss it with your provider.
What happens if you feel like your doctor just dismisses you and says that's a normal part of your period? Because that's something I hear a lot from my patients is, well, I tried to talk to my family doctor. They just said it's normal. Take an Advil.
Right. It's unfortunate that people often get dismissed, or lots of people get dismissed. And unfortunately, that's more likely to happen if you're a woman at a healthcare provider, probably with all different kinds of symptoms, pain being one of them. And, what I tell people is it can be good to go in having read the information yourself. So to be able to say, look, I read in Dr. Jen Gunter's book that this isn't something that I should be expected to tolerate. And look, there's all these treatments here. Bring in the book, have it underlined. Look on the Society of Obstetricians and Gynecologists website for Canada, the SOGC, and see if they have any information about painful periods, and print that off and take that in. I mean, you shouldn't have to do that, but you also need to get the care you need, and waiting for the healthcare system to sort of, fix itself. You'll probably be menopausal by then. So,
yes.
So you want to go in having read and knowing what the options are. I'm often accused of, not believing in complementary and alternative medicine. And I'm like, well, there's evidence-based medicine, and then there's unstudied hypotheses. And, it's not because something's a prescription, whether or not I like it, it's whether there's data. These other things, herbal products and such that are mentioned in the book, they're all based on, lower quality studies. That doesn't mean people shouldn't try them. But if you want to have informed consent, there's a big difference between saying, there's 2 low quality studies, now maybe I'll give it a try, versus there's robust evidence, right? So, and especially considering, many supplements can be adulterated or may not contain what they claim, people really need to spend some time thinking about what they're putting in their body.
Absolutely. And that brings up this huge topic, which is misinformation, disinformation. And you're really good at explaining the difference between them. So maybe we'll start there. Just what is misinformation versus disinformation?
Sure. So misinformation, I like to think of it as a mistake. So misinformation, mistake. So that's somebody passing along incorrect information, but there's no malice or behind it, or they're not someone who would have necessarily known better. So meaning somebody on Instagram who saw an influencer who they thought was an expert, but they didn't have the ability to say whether that was correct or not, and they passed that along. So I would consider that misinformation because they didn't do that on purpose. They didn't know. Versus disinformation, I really think about it as a frank lie. And, that's somebody who should know better. And, if you're going to call yourself a healthcare provider, then you should be held to the disinformation standard. So this isn't just physicians. If you're a chiropractor, if you're a naturopath, then if you're spreading incorrect information, I would consider that disinformation because you should know better.
Yes. And the problem is, of course, they all go by doctor.
It is a problem. Yeah, doctor's not a protected term. And, there are doctors who are PhDs who know like everything about one aspect of the menstrual cycle.
Right.
And they may be very well equipped to have a discussion, but they're not a medical doctor, so they don't prescribe things. But they might study things and they may know a ton about a specific medication, versus you might have a medical doctor who knows a ton about something, or maybe it's not even their area of expertise. They're like a heart surgeon selling a bowel supplement or something like that.
Right.
And then you have people like naturopaths and chiropractors who don't have the quality of medical training that rises to the level of a medical doctor. The training is really not on the same par.
And it's really tempting. You see something that seems like a miracle cure. You don't have to put any effort in, just $20, $40. And oh my gosh, it's going to cure everything.
It's really an interesting use of rhetoric. So in rhetoric, there are what we call, God terms and devil terms. And God terms are words that we automatically assume a positive connotation with. So pure, clean, natural, organic. If I say those words, I don't even have to say much else about the product. You're going to assume it's good for you. And if you look at purveyors of alternative medicine, that's what they use. They use that terminology, which interestingly overlaps with purity culture, right?
Right.
Now, doctors are stuck with devil terms. We have to talk about risk. We have to talk about cancer. We have to talk about abnormal bleeding. We have to talk about blood clots. We have to talk about all of that because it's ethical. And so, when I start talking about a risk of, blood clot maybe being 1 in 10,000, that can make people automatically assume that that's something that's very risky,
right,
even though, you have to put the risk in context. And humans are pretty bad at parsing out risk. So it does create, I would say, a communication challenge even before you're out the gate. So never mind the 12-minute doctor's visits or the fact that, you're stuck with telling the truth. You have, right out the gate, you're stuck using devil terms. And so the propaganda is working against medicine.
Yes. And then as you brought up, it's hard enough when you have natural health providers who aren't always ethical or who are selling products. But now I've noticed an uptick in, as you mentioned, qualified, even, Menopause Society certified or board certified physicians who've kind of gone to the dark side, right? They're using their credentials to gain the trust of patients and then leading them down.
Yeah. So having a medical degree is not a guarantee that you're going to get ethical or good quality care, which is really sad. And I think it's atrocious that, the College of Physicians and Surgeons doesn't take a stronger stand on that. It shouldn't rise to the point of, needing someone to just be full on anti-vaxxer 24/7. The whole idea that physicians are selling supplements, that shouldn't be allowed as far as I'm concerned. Yeah, I mean, it's huge money. In the States, there's this guy who's an anesthesiologist who came up with a liver supplement called Liver Shield. And it's advertised, specifically to young women with, how you protect yourself basically from binge drinking. It's never quite said that way, but the pictures of the young women holding lots of alcohol and in bars would make that suggestion, right? And I mean, it hasn't been studied, and it's been out for, a year and a half. And according to an email they sent a friend of mine that they were trying to recruit to promote it, they're on track to make 7 figures. 18 months after it's come out. So how do you argue with that kind of money? I mean, ethically, I would be ashamed to do something like that. But I think it's very easy for people to start to believe their own press. And when there's all kinds of money to be made, it creates problems. I mean, pellets, the same thing, completely not recommended, much higher risk of having complications. These are, for people who don't know, these are pellets with either estrogen or testosterone or both that are implanted. They're not batch tested, which means you actually have no idea how much hormone is in each tablet. It's managed with a proprietary algorithm, meaning they check blood levels and then decide on dosing based on that, completely unstudied. I see people with balding, clitoromegaly, acne, voice changes. We know it's associated with a higher risk of bleeding problems and even endometrial cancer, but it's basically a cash cow. People make incredible amounts of money, in this short little procedure.
Right. And supplements are not always without risk. They're not always safe. And it may only cost you $49.99, but you owe it to yourself to fact check. How can a patient who's considering trying something, how can they do their due diligence and make sure this is science, not science backed, but evidence based? So
the problem is they can't. So Health Canada, everybody's like, oh, it's approved by Health Canada. Well, Health Canada doesn't test these products. They're just, if the company says, well, this product contains this, Health Canada goes, okay. Like, there's no testing. There was a study from Edmonton in 2018 that looked at prenatal vitamins they pulled off the shelf in Edmonton, and 20% were contaminated with lead. Mm-hmm. So, and that's a supplement that we actually recommend, right? So we have good data for prenatal supplements that they reduce the incidence of neural tube defects if they contain, at least 400 micrograms of folic acid. We recommend, usually about 600. So, so we have good evidence for prenatal vitamins, right? We have, some good evidence for a multivitamin for people who've had bariatric surgery. So I would say if people want to know if there's good evidence for their supplement, they should find out what the relevant professional medical society is for that sort of indication, if you will, and see if it's in the guidelines. So for example, you can take SOGC, Society of Obstetricians and Gynecologists of Canada, put that into your Google search term and put prenatal vitamins and hit enter, and that will force the articles that mention the SOGC to come to the top. So then people can see, oh, wow, this is something recommended by the SOGC. So then now they know that taking prenatal vitamins is something that's recommended. Whether they're getting what they claim is another story, and that's a real big problem that governments really haven't decided to get into. I mean, they certainly could. Health Canada could say to a prenatal vitamin, you have to submit this data, this testing, you have to pay for us to do this testing. They don't.
Right.
So
why would they?
Right. Well, I mean, they could make money off of it. If I was Health Canada, I'd be like, okay, great. We're going to
Health Canada. But I'm saying, why would you, if you're selling something anyway, without having to prove anything?
Right. Why would you? Yeah.
Spend the money on a clinical trial?
Oh, yeah. Well, and it's not just the clinical trial. And this is something that's a really important concept. So say I want to study vitamin B6 for PMS. Mm-hmm. and I buy a bunch of vitamin B6 and I randomize people. Half the people get placebo and half the people get vitamin B6. Unless I've batch tested each sample bottle, I don't know if they contain the same amount of vitamin B6. Versus if I'm testing a birth control pill, I know within what margin of error each pill has what it claims. So if you get results that don't show it works, maybe it's because half the pills didn't have enough vitamin B6, or maybe it's because vitamin B6 doesn't work. So you can't even answer the question. But say I have batch tested samples and I know, okay, every single person who took vitamin B6 got the right amount. I can't be sure that the one that you buy over the counter has that amount. So this is where all the problems are. And so when you have something that is pharmaceutical, you know it contains what it claims, which is why I believe that all supplements should be pharmaceuticals, which would also affect a lot of less qualified people dispensing things. But you deserve to know what you put in your body. If you look at things like metabolism boosters, many of them are adulterated with contaminants and with things that are harmful. There was a recent study in the States that found that one was even contaminated with a substance that had not been tested in humans. So, and I would put menopause and libido supplements into that category because it would be very easy for someone to just put estrogen in that supplement and then you feel better because you're taking menopausal hormone therapy, except you don't know you're on it and you don't know how much you're getting. And so you're now putting yourself at risk for endometrial cancer.
Absolutely. Wow. You mentioned the birth control pill, the pill. It's funny because I was thinking about this last night. You know, there are so many pills out there and yet everybody knows the pill.
Yeah. I mean, I think it's important for us to remember that the way studies were done in the 40s and 50s and 60s and probably 70s don't meet the ethical standards of today. There were many awful trials done. I could have written a whole chapter about, you know, terrible things where, you know, where things were done without consent. You know, there's a study that I often reference where, you know, the one that we learned about how bacterial vaginosis can be transmitted. And the person who was doing the study actually took vaginal discharge from women with BV and put it into the vaginas of people without. And they didn't know that this was, you know, they just thought they were in a study to learn.
Wonderful.
So yeah.
Wonderful.
So that's awful, and we need to know about that. But that doesn't mean that the data that we learn from that, you know, gets thrown out. It means that we need to be, we need to never do that again, and we need to have ethics, and that's why we need human subject research. And that again gets back to all these supplements because they don't have research, they don't have the ethics behind many of these supplements. I mean, when you look at multi-drug supplements that are out there, they've never been tested in human trials, or most of them haven't been. So what's the ethics of that? Putting a product on the market that's unstudied.
One of the main questions I get from women when I tell them, let's try an IUD, right? And you may stop having menstrual period, like you may stop bleeding, or let's try this contraceptive pill, and it will work to kind of thin out your uterine lining, and you may not have periods. They're very, very concerned. Well, isn't it unhealthy not to have a bleed every month? And in fact, it's not. It's not dangerous.
Right. So if it were dangerous, how would we get through pregnancy? Nobody, you know. So what happens to the lining of the uterus during pregnancy? It actually gets very, very thin, and very similar to actually the effect from the birth control pill or the hormonal IUD. So, you know, the mechanism for a menstrual cycle and the fact that if you don't bleed when you're having a normal menstrual cycle, that's certainly not a concern from a buildup of toxins or anything like that. But if you're not having a period, we need to know why, because there could be medical reasons. If you're on something that we know takes your period away, then it's not a concern if you don't have your period. And so, yeah, when you're on the hormonal IUD or hormonal pill or the Nexplanon or the Depo-Provera injection, that there just isn't a lining that develops. And because, you know, if you stop the pill every month to have a withdrawal bleed, it's generally much lighter. It's that withdrawal of the progestin that triggers the bleeding. But if you stayed on it over time, there would just be very little lining there. So there's nothing to come out. And it's not harmful. There's just nothing there.
I just want to ask you a question about oral contraceptions. There's two types of pills. So there's the monophasic pill, which is you basically take the same amount of estrogen and a progestogen for 3 weeks, and then you have a week off typically. And then there's something called a triphasic pill, which I do see come into my practice every once in a while, or I have women who say they prefer it for whatever reason, or they've been told it's better. Could you explain the difference and what advantage one might have over the other?
Yeah. So there aren't that many individual variations between the different pills. And there's like a gajillion pills on the market, but there's, like 4 or 5 progestins, and up until recently they all had the same estrogen. So the only real way you could have a difference would be by either, changing the progestin or changing the amount. And so sometime I think in the 80s there was this grand idea that you would come up with a pill that mimicked kind of the change in hormones. So as the estrogen rises and have that reflected in the pill. It was complete marketing. It was, I know someone who was heavily involved in pill research in the 1980s, and he's like, yeah, it was all marketing. It's like absolutely no science behind it. But it really took off because one of the triphasic pills was the pill that was studied for acne. So everybody wanted it because it was the one that reduced acne. However, every pill reduces acne. Every single pill reduces acne. We don't actually really need studies to do that because we know that's how it works biologically. But they were the first ones to do it, and so they got an approval indication for it. So it was very smart marketing,
right?
But there's no science behind it. And actually, most people feel better without fluctuations in hormone levels. So if somebody came in and told me, I love my triphasic, that is the pill I must have, I'd be like, okay, sure, you can have it. But I would never recommend it to someone coming in. I mean, the best form of contraception is the one that you're going to use. So if you love one and you are a team tricyclic, okay, great, you may have that pill because studies tell me that you're more likely to stay on the one that you like. But if someone's coming in and asking my opinion, I would never prescribe a tricyclic pill.
Okay. And it sort of, I hate to state the obvious, but the point often of taking an oral contraceptive is not to have the fluctuations in your hormones.
Right, exactly. So people feel better. It's the fluctuations that often cause symptoms, mood type symptoms, PMS type symptoms, and not the levels. But the other thing is, if you want to take your pill in such a way so you don't get a period, you can't do that with a triphasic. You have to have the same level of hormone. So you're kind of stuck. You have to take it 21 days on, 7 days off. So, it's, I would say it's got a niche market of people who tried it and loved it. A lot of pill lore is marketing. So, I think it's just important for people to, use the contraception that they like.
Right.
Yeah.
And of course, there are other reasons other than menstrual control that women take the birth control pill. And you talk about a big example is PCOS, so polycystic ovarian syndrome. This affects a lot of women. Some women, it takes them a long time to be diagnosed because putting the pieces together can be tricky.
Right.
But oral contraception can be a first-line treatment for PCOS. So often we associate it, and certainly right now with a lot of what's going on in the U.S., there's a lot of thinking about contraception only in terms of birth control. But it is a very effective treatment for other disorders of menstruation.
Yeah, it's really important that we emphasize that because, first of all, not everybody needs contraception. There's some people who partner with women. There's some people who are just abstinent. There's some people who just, they're not having sex right now. And it also, ignores the vast ways that hormonal contraception can help. So estrogen-containing oral contraception is, one of the most evidence-based things for polycystic ovarian syndrome because it helps to reduce the abnormal levels of androgens. It helps to control the abnormal bleeding, and it protects against uterine cancer. So it really does a lot of very good things for people with polycystic ovarian syndrome. It's not the only treatment. There's other treatments too, but it's a very, very good, especially for people who have higher levels of what we classically call the male hormones, the androgens. So it's very effective for that. But we use it for control of abnormal bleeding, if you're having heavy periods or regular periods. And we also use it for people who are having bad symptoms in the perimenopause transition or menopause transition. It can be used to control irregular bleeding then. And also you've got the estrogen, it can control the hot flashes.
Yes. I mean, just to share a story, my daughter was 10. She gave me permission to share this, but she was 10 when she got her period. And unfortunately, she had these because, the brain ovary axis just wasn't developed at all at that point. She had periods that would go for 90 days straight.
Right.
There were no breaks, nothing. She became anemic. We took her to the doctor. They ruled everything out. And ultimately, we made the choice to have her start an oral contraceptive pill.
Right.
It was that or she was going to bleed to death, right? So she certainly wasn't requiring it for contraception. It was mortifying for her to be a 10-year-old going to school day after day, worried about leaking into her seat. It gave her her life back. And so I think about that, and I think about a lot of the perimenopausal women I see. Again, you're right. It's that for heavy bleeding, it can be a godsend. But just for anyone who doesn't know what PCOS is, do you mind just giving us a brief explanation of what it is?
Yeah, so it's a complex endocrine disorder that is the most common endocrine disorder affecting women of reproductive age. And despite the fact that it's that common, we actually know pretty little about it. It's classically associated with elevated levels of androgen, so male hormones, with irregular bleeding and with what are called polycystic changes on ultrasound, meaning follicles develop and then they kind of stall out. And then there's this abnormal production of hormones. It's also associated with an increased risk of metabolic syndrome, which is a risk factor for diabetes, an increased risk of heart disease. There's a study that came out showing it got an increased risk of suicide associated with it. And we don't really understand, it's also associated with insulin resistance. So there's all these things that go along with it. And we don't understand kind of the chicken or the egg part with it. There are many sort of different metabolic abnormalities associated with it. And so from a cause and effect, like, we don't really know. So anyone who tells you they know the root cause of PCOS is either an idiot or they're lying. I mean, we don't know the root cause.
Right.
There's been a lot of research in it. It's actually very old, meaning that many of the genes for polycystic ovarian syndrome have been around for thousands and thousands of years. The incidence is stable in different populations around the world. So meaning it's pretty stable. And we just don't really have a good handle on it. Again, we know that there definitely are treatments for it. But I think one of the really important things is for people who have PCOS is to be very mindful of their metabolic health as well. Because often we get fixated on the bleeding issues, but people have to make sure that they're getting screened for their cholesterol and diabetes, that exercise is a very effective way to help with insulin resistance. These are things that are important to think about the metabolic health as well.
Right. And your book goes into a lot of the history, or at least the theories around
Right.
PCOS. And so because it's thought to be inherited through the genes, men inherit these genes too.
Yeah.
And this led to one of my absolute favorite lines in your book. So there's this thing called sexual conflict that you talk about.
Right.
So maybe this is something that offers a survival advantage to the species, but the women suffer all of the consequences. So in other words, it can maybe allow for reproduction later in life for women because they get some stability of their hormones later in life, but they also tend to have a little bit more fat deposition. So maybe they have a survival advantage that way, but the men get all of the advantages of the genes and the women bear the brunt of it. And so as you famously say, sometimes I just want to punch evolution in the face.
Yeah. I mean, these are all theories because we don't really
Right.
know, because also we don't know what it was like 10,000 years ago. We ate different diets. We were far more active. And so how expression of those genes might have looked 10,000 years ago might not be how they look today. Right. But yeah, so one theory is there is, a theory, something called sexual conflict, meaning the genetics are advantageous for one half the population and disadvantage for the other. And that, one half the population is basically sucking it up. And so one theory, and again, this is not proven, but one theory with PCOS is that men that carry some of the genes may have enhanced fertility. So meaning that, the women who have it are sucking it up to pass on the genetic advantage to their male offspring. Again, all theories, very interesting, but I think it also reflects that we just, we don't know what we don't know. It's such a complex disorder. Mm-hmm. And this is, one reason why we need a lot more funding for, women's health. Because if you look at, the amount of funding that we've had for, very complex medical conditions. So for example, Crohn's disease, right? Or asthma, also both very serious conditions, affecting, different percentages of the population. We just don't have that research with something like polycystic ovarian syndrome to understand the basic biology. And if you don't have a full understanding of the basic biology, it's pretty hard to design treatments, right? Like you need to, so, we need a lot more research in this area. And I would say, we elect the people that distribute, that make decisions about what gets funded.
One question I really wanted to ask you. So there was one section of the book where you're talking about more permanent forms of contraception, mm-hmm. right? So tubal ligation, so mm-hmm. tying your tubes basically. And you indicate in the book, you state, anyone who's 18 or over who wants to have tubal ligation should have it. I immediately thought of my 18-year-old daughter who goes around, ew, I don't want kids. I'm never having kids. And I know that, she's 18. How do you tease out which patient might be more confident in that decision versus offering them something that's maybe a long-acting reversible contraceptive method as a stopgap to make sure that they're not going to regret that decision.
So I think it's really important that physicians not impose how they feel about it on their patients. Mm-hmm. And, if a well-counseled 19-year-old came to me and wanted a tubal ligation, I'd be like, sure. The key there is well-counseled. So you come in and you understand the risks and the benefits. You understand that, there are these options, that there's a hormonal IUD that will stop bleeding, that there's, a copper IUD, there's an implant. Some people just don't want hormones. Some people really know. The incidence of regret is lower than people think, meaning regret to the point where you would actually do something about it.
Okay.
And we allow 18-year-olds to make permanent decisions about having an abortion, right? That's an irreversible decision. So I think that if we can trust an 18-year-old to make a decision about their body for an abortion, we can trust them to make that decision. And do people change their minds at different points in their life? A small percentage do. It's about the same for men and vasectomy, but men generally aren't required to jump through consent hoops and things like that, right? So
True.
I think that, the important thing is here is well-counseled, because sometimes people come in and they're just like, well, I heard an IUD is really bad for you. And so that person, if they decided to have a tubal ligation based on believing an IUD is really bad for you, that wouldn't be an informed decision. But if people are fully informed and they have all the information, it's their body and their choice.
That's a great explanation. I have to say, after reading your book, which I devoured in a week, and got so much out of it because you hit us with the science. And if that's not going to work, you hit us with the backstory. And if that's still not going to work, you hit us with logic, right? And so something is going to get through to everybody in this book. And you will certainly feel well counseled. You'll feel empowered. You'll feel better able to advocate for yourself. And you will see the wide variety of choices that are out there because it's all about choice. It's all about autonomy.
Right. You can't be an informed and empowered patient without the right information. So, I see people come in and say, well, I took this supplement. Well, what's in it? I don't know. Okay, that's not an informed choice, right? Do you know what percentage of people who take this supplement get an improvement? Well, I don't know. I can tell you with polycystic ovarian syndrome, with endometriosis in general, what percentage of people will have a benefit. So people deserve to have data. We need more data for everything, but you can't be an empowered patient with inaccurate information or with inadequate information. And so I feel like my role with this book, with the other books that I've written, is trying to sort of level out that knowledge gap between providers and patients so people can understand when maybe they're not getting the information they need in the office, or when they're being led astray, when they're having a doctor tell them that they should be sucking it up with heavy periods, like, your daughter when she was 10.
Yeah.
I mean, what's the alternative? To let her bleed to death? Like, of course she needs to go on hormonal contraception, right? Like,
there's free bleeding. I don't think so.
And so, I'm all about choice in all aspects of it. And to have choice, you need to have information. Knowledge about your body should be democratized, right? This isn't something that should come from an ivory tower, but also we have recognized experts. And just like I'm not the person to, talk about the Boeing Max, airplane problem and make decisions about how Boeing needs to fix that problem. That's not my area of expertise.
Right.
And I think that we are in this really sad time where expertise is being dismissed, or that everybody's an expert. And I would just leave people with the thought that there is a difference between data and knowledge. Right. So, someone spitting out some statistics, or someone, understanding how to apply that to your health, that's something that takes time and effort and training. And you want to make sure that, you're seeing somebody who has that training, but also who's going to listen to you and consider, when I see people come in, if there are people who make choices with their bodies all the time, I wouldn't make, but if they're informed, that's their body and their choice. I'm totally cool with that. You know, it's when people come in and they've been led astray that's, you know, and then again, my ire is directed to the people who led them astray. There's all kinds of data to show that when people research on the internet, they are more likely to end up less informed because people who promote snake oil are really good at search engine optimization. Yes. So the stuff that comes up first, the stuff that is popular, is not necessarily stuff that's accurate. In fact,
and as you mentioned, you hear something 5 times, you start to believe it.
Exactly. Propaganda works.
So thank goodness you're speaking out and say this message again and again and again so that people are well informed and can effectively advocate for better health. So thank you, Dr. Gunter. I really appreciate this opportunity to talk to you, to learn from you. And I know my listeners will appreciate it. And I really welcome back to Canada. We're so lucky to have you. You're a national treasure.
Gens unite.
Yes. If you missed episode 1 and 2, you may not have met my 2 secret weapons, my co-pilots, my daughters, Maddie and Becky.
Hi, I'm Maddie.
Hi, I'm Becky.
We're going to have a little fun with some questions and answers to see if you know me as well as I know myself.
Ooh.
Right? We're going to get this started. So, Becky, you're going to ask the questions, and we're going to see if we get the same answer.
Which celebrity did Mom date?
There's so many, guys. Okay, ready? Yeah. 1, 2, 3.
Oh my God, I spelled his name wrong.
Oh, you did.
But I was just off by
But you're right. It was Corey Haim.
Yeah, that's insane.
Yep. I dated him in the mid-90s. I had such a crush on him. I had his picture in my wallet when I was a kid. And then I was working at a bank as a bank teller, and he walked in and asked me out, and I said no. And then my sister basically forced me to say yes. So we went on a few dates. It was really fun, memorable. Question 2, because your dad's listening to this.
What's the way to get Mom to laugh?
Oh.
1, 2, 3. Oh.
Oh my God, we were so close.
No way. We were so close. So I said, show me a funny dog meme. And Maddie said, show her a pug video, which is very, very along the same lines.
Yeah.
I think that counts.
I feel like mostly if I'm sending them to you, they're pug videos.
They probably are.
I know you love pugs.
I do.
So.
Okay. Well, okay. Question 3. We're on a really good, off to a good start here.
What's Mom's guilty pleasure?
And as I write this company can feel free to send me some freebies.
Oh no, I think my first answer was right.
Okay, 1, 2, 3. Dairy Queen Blizzard.
I said Selling Sunset, the Netflix reality show.
They can send me freebies too. You know, any mansions they have. Beachfront mansions they might have lying around.
I feel like you're one of those people that sometimes judges me for watching a lot of reality TV, but then I put on Selling Sunset and you actually watch it.
You grab the popcorn like you're
you're but
locked
don't mistake my jealousy over the amount of free time you have at your age for judgment.
Okay.
No judgment, just jealousy. Final question.
Okay, last question. Oh, which Friends character would Mom be?
Male or female?
Yeah.
Okay.
You're asking that
2,
you think I'm wrong.
3. Yes, all day, every day, Monica.
Yeah, I said Monica as well, except my W looks like an N, but oh my God, that's such a bad N.
It really is, but we all got the gist, because there was no
Sorry, we have to redo that.
Mawaka on the show,
because
so I know what you meant.
It was,
I'm Monica all day. You guys know that. I'm always chasing you to clean up. I'm sad to see you guys head back to school, but thank you for, coming in and being a part of this with me.
Well, thank you for having us.
And we'll see you next time on Medsplaining. Don't forget to follow us on social media, Instagram, Facebook, LinkedIn, YouTube, anywhere you find your podcasts. Have a great day. Don't forget to follow us on Instagram, Facebook, LinkedIn, and TikTok at Medsplaining. If you have any questions, shoot me a DM. And if you like this episode, the best thing you can do is tell a friend or rate and review it wherever you listen to your podcast so other women can discover it. And don't forget, if you're listening to this, you may be happy to know that we video every single episode, so you can watch it if you prefer on YouTube. See you next week. Medsplaining is produced by Ghost Bureau. Thank you for tuning in to Medsplaining. While we strive to provide accurate and insightful information, this podcast is not a substitute for professional medical advice, diagnosis, or treatment. The opinions expressed by our host and guests are their own and should not be interpreted as medical advice. Every individual's health situation is unique, and it is crucial to consult with a qualified healthcare provider regarding your specific concerns and conditions. Additionally, any links, resources, or references mentioned in our episodes are provided for informational purposes only and are not sponsored by Medsplaining. The producers and hosts of Medsplaining assume no responsibility or liability for any actions taken as a result of listening to our podcast. We encourage you to use the information presented here as a starting point for discussions with your healthcare provider. Information and references are subject to change based on scientific evidence as it evolves over time. The hosts and producers of Medsplaining are not responsible for future changes to the information and references and assume no obligation to update based on future developments. Remember, your health and well-being are paramount. Thank you for listening, and we look forward to exploring more topics in women's health with you in future episodes.